Well, good afternoon, everyone, on this hot, humid day. Welcome to our monthly Lunch and Learn with Johns Hopkins Geriatric Workforce Enhancement Program. We're pleased to provide a professional development and community education. Today's topic is the GUIDE program, and we're really excited about this across the state, so we're so glad that you joined us. Our recording today is recorded and will be made available to everyone after the closing of the webinar. So we will be able to send out the PowerPoints, the recording link, as well as any resources that are provided. I would like you to make note that next month we will have a happy summer and not be meeting, but I want you to save the date for September the 17th. We're going to be talking about biomarkers in assessing for dementia and what we know about that with Dr. Esther O from Hopkins. So I'm going to turn the webinar presentation over to Jane Marks, and she will introduce our guest speaker today, Dr. Cynthia Fields, and tell you a little bit about our panel guests.
Thank you, Wendy. Will you share the slides? So today we're going to hear about the GUIDE model. As Wendy was saying, we're excited to bring that to you. And our first speaker is Dr. Fields, who's going to provide us an overview of the GUIDE model. Dr. Fields is an assistant professor of psychiatry and behavioral science here at Johns Hopkins, and certainly one of our experts in dementia care, but also has been involved in our GUIDE model and some of the history. So we're excited that she's able to share with us her background about this. And so the next slide. Thank you.
I guess that's me.
And the next one. So we're going to start this off, Dr. Fields. What is the GUIDE model and the background of this new care model? How did it all come about?
Yeah. So next slide. So let's start a little bit with the background. And of course, this is a Hopkins focused talk. So I'm going to talk about Mind at Home. So the Mind at Home model of care that was developed at Hopkins. That's our website. You can go to the next page. So Mind at Home, maximizing independence at home. This was a brainchild of Quincy Samus. You can see her picture there, Deirdre Johnston and some others. And Mind at Home is a care navigation program. It's specifically for people with dementia who are living at home with their family, typically with their families. So dementia or other cognitive impairment. And Mind at Home, it's not only comprehensive, but it's scalable. And so that's important when we talk about GUIDE. So how can we do this comprehensive care for as many people living with dementia as possible? And for Mind at Home, they had a memory care coordinator. And you can think about that as like a community health worker type of person, really boots on the ground, supported by an interdisciplinary team, including clinicians like myself. And I will spare you all of the details, but just know that Mind at Home, it's research backed. There is evidence that this is an effective strategy that improves outcomes for patients or for people living with dementia and their care partners, and that it also reduces healthcare cost. And so there are trials to back that up in really diverse populations of people. And so even though we know that the dementia care like Mind at Home, that it works in a sort of public health way, it saves money, but for an individual person, prior to GUIDE, for an individual person living with dementia and their care partner, it was costly. This care navigation was costly and not covered by Medicare until GUIDE. So as you can see, I'm totally excited about GUIDE. All right, next slide. And I'm not going to go through this in detail, but just to kind of conceptualize what does care navigation or comprehensive dementia care look like? And so these are some of the care needs that we address. So in Mind at Home, we're looking at the patient or the person living with dementia and their care partner. So we're looking at care needs, everything from cognitive needs to home safety to advanced planning, like legal guidance and such. And then for the care partners need education on dementia. It's a moving target, as most of you know. So they really need ongoing education, skills training. They need like backup supports if something happens to them and they're the primary caregiver. So a whole long list of needs for both of those parties. And for Mind at Home, there are short-term goals and long-term goals. And basically, we're trying to improve quality of life and help people to use available healthcare services and really to reduce the burden on caregivers. And then long-term, we want people to stay at home and stay well. We want them to have better care at less cost. That's the ideal. Next slide. And so I'm not going to go through this list, but I just want to give you one like practical example of what
Yes,
Mind at
I can
Home
hear you.
did. What was that? Oh, I thought I heard somebody, sorry. I want to give you one practical example of what Mind at Home did. So this is a lovely lady with cognitive impairment who was anxious and agitated and picking her skin, and they developed a twiddle muff. We call it a twiddle muff, and it's this sort of round, kind of padded piece of fabric with lots of things to twiddle with on the outside and on the inside. And so the legend has it that when this lovely lady first put her hands into the twiddle muff, this is the picture, and it really helped to calm her. So this is one really practical example of the things that care navigators help people living with dementia to do. Next slide. And so probably at the time, nobody heard of this, right? But in July of 2023, the Biden-Harris administration announced the GUIDE model. It's really been around for that long. And the GUIDE model is based on evidence not only from Mind at Home, but from 5 other dementia care models throughout the country. Next slide. And so what is GUIDE? So GUIDE is what CMS covers, and GUIDE stands for Guiding an Improved Dementia Experience. And it's a model of care. And really, it's an innovation from Medicare and Medicaid, and it's a new Medicare benefit. And it provides this comprehensive dementia care management to beneficiaries at no cost to them, no cost to the patient. And it's a standardized set of services. I put that in italics because our program and throughout the country, we really have to abide by a certain set of deliverables for everyone in the program. And it's designed to support the person with dementia and their care partner. And at the time that I made this slide, there were over 300 programs in the US. Now, programs have dropped off for a number of reasons. They haven't been able to continue this. It's considered a pilot program. And the hope was that GUIDE could reach at least 200,000 people living with dementia. And so in Maryland, we have 4 programs, and there are also like 4 brick and mortar programs like ours, but there are also many virtual options if someone is living in a zip code where GUIDE services aren't provided. And the goals of GUIDE, broadly speaking, we want to improve quality of life for the person with dementia and their care partner. We want to avoid nursing home placement. And we really want to help people stay in their homes really through the end of life, if that's their goal. And so this is a pilot program, it's a test. And so what Medicare is hoping to do, that's why the service is coming free to everyone. What Medicare is hoping to do is to reduce healthcare costs, reduce expenditures, while at least preserving quality of life, if not enhancing quality of life. So it's really exciting because this is a preventive effort on the part of Medicare. So it's wonderful. And we're hoping it'll become a permanent benefit. Next slide. Looks like that's
So with that, what are the benefits and services that participants can receive with the GUIDE model, Dr. Fields?
Yeah. So this is a complicated slide, but big picture, it really has 3 facets, GUIDE does. There's the care coordination and management. So this boots on the ground care navigator, we have 2 in our program, working with the team, like myself, Dr. Amjad on the Bayview campus. And we're trying to manage the dementia, but also trying to manage all of the other kind of medical comorbidities that interplay And we really want to provide this ongoing monitoring and support, including times of care transitions, which I'm sure everyone in the audience knows are really challenging. So went to the emergency room, got admitted, came back home, sort of all of the things that can go wrong in that scenario. And we're really trying to avoid people going to the emergency room in the first place. And then a lot of caregiver support and education, that's a big piece, both sort of individually between the care navigator and the care partner, and sort of more broadly speaking, programs for the caregivers. And then another piece that a lot of people are really excited about is that there's money for respite services. So Medicare has never paid for respite care previously. So for people in the program who are moderate and high tier, and I'll get to that in just a second. So not everyone, but a nice fraction of people involved in the guide program have $2,500 of respite money per year that they can use specifically with an agency that we contract with, that Hopkins contracts with. And the person with dementia and their caregiver, they don't pay a penny. We pay the agency, these agencies with whom we contract. Okay, next slide. So that's kind of big picture. And so quick intro to our team. It's a care navigator and a dementia proficient clinician. This is sort of the bare bones model from Medicare that we have to have. And so this is Amaya and Lindsay, our two care navigators, and then myself and Dr. Amjad from Bayview. Next slide. So if you're involved in Guide, you'll be meeting with either Amaya or Lindsay. They are both very lovely. And then what we have to deliver, here's this whole big graph. And so, time is limited, but I just want to show you some of the key points. There's a very comprehensive assessment, and that's the one that we used at Mind at Home. So all of these care needs for the person with dementia and the care partner, we provide a care plan. There's 24/7 access to an on-call clinician for emergencies, not for day-to-day, like, we're all sleeping like we have jobs too, but like an emergency in the middle of the night. So instead of automatically having to take someone to the emergency room, maybe that has a sudden onset of behavior, there's someone you can get in touch with. And really ongoing management and monitoring, referral. We do care coordination, say between primary care and some specialists. We're here to support the care partner. There's a piece of medication management, sort of medication reconciliation, making sure that someone is taking everything they're supposed to and there's nothing in there that's particularly not good for memory. And then a lot of that transition work that I talked about. Next slide.
So the next question is, can anyone with a memory issue be referred to Guide, or are there specific eligibility in regards to that?
Yeah, great question. So for the purposes of Guide, someone has to have a dementia diagnosis. So for Guide, simply memory loss or mild cognitive impairment, which is a pre-dementia syndrome, those at this time do not qualify for Guide services. So a dementia diagnosis can be mild stage, but it has to be dementia. It can be dementia from any source. So Alzheimer's disease, vascular, Lewy body, Parkinson's, frontotemporal, the whole list. And this is a Medicare program. So it can be someone of any age as long as they have Medicare. And it's for traditional Medicare, not the Medicare Advantage plans. Just traditional Medicare, you have to have Part A and B. That's the outpatient piece. And this is for someone not already in a nursing home or in a memory care or such, because that's what we're trying to avoid, right? We're trying to help someone stay at home as long as possible. And people cannot be enrolled in hospice because that's a different Medicare benefit, and they can't be enrolled in a PACE program, same thing. That's a different Medicare benefit. So dementia and straight Medicare are the big ones. And it's a voluntary program. And then based on the information that we get in terms of the staging of dementia, the severity, like is this mild stage dementia, moderate or severe, and the amount of burden on the care partner, those two things, dementia severity and the burden on the care partner, are what help Medicare decide if you're in a low, moderate, or high tier. And it's the moderate and high tier that get the respite care. Sounds complicated. We handle that part. We input the information, Medicare decides. But I say all of that to say, if anyone is going through the enrollment process for their loved one to receive guide services, when they ask you questions about caregiver strain, and please don't minimize. It's important to be really honest about how challenging being a care partner is, because that entitles you, that allows you to get the amount of services that you need. I'll leave it at that. Next slide. And then that's our guide webpage. And you can find that basically by Googling Hopkins. And then this is our guide contact information. Penny Ross is our program manager. She's the starting point. And you can also find this information online. So thank you so much. That was a bit of a whirlwind, but we're limited on time. Thanks.
Thank you, Dr. Fields. I think the next slide actually, is that our panel, Wendy? So this is our guide panel that we have. And I think Dr. Fields will come back because the person who was representing Hopkins was unfortunately not able to join us at the last minute. So we're going to hear from several of our guide programs in Maryland. This is not everyone, but a good majority. So we're excited about that. Next slide. So Dr. Fields, I'm going to let you start again.
Yeah, so this, we already went through these. It's a bit repetitive because I'm doing last minute substitution. We went through one of those. I do want to mention if someone wants to receive guide services who does not already get medical care in the Hopkins system, we need medical records. That's the main part of that. And then the next slide talks about our zip code. And so I forgot to mention, so zip code does matter for the non-virtual programs. And the reason that it matters is because a home visit can be part of the services that we provide. It's not required that we come to the home. We can do the assessment by video or by phone. But because we offer a home visit, we can't travel to all corners of Maryland. And so this is the list at this moment for the Hopkins Guide Program, the areas in Maryland that we serve. It's an evolving list, but this is where we are at the moment. Thanks, Jane.
Sorry, my slides were a little.
Oh, I'm sorry.
Late.
Our next speaker will be from the Gilchrist Guide Program.
Good afternoon, one and all. As Jane mentioned, I'm Amy from the Gilchrist Guide Program. Many of you may be familiar with Gilchrist's hospice program, which we've been providing to the Baltimore community for over 30 years. However, Gilchrist has also been providing home-based geriatric services for more than a decade, and that is the foundation on which our guide program was built. So our guide program is delivered through an interdisciplinary team that includes a nurse and a social worker. And we serve as the care navigators along with our team of geriatricians and geriatric nurse practitioners. We work with individuals living with dementia and their care partners to provide assessment, care planning, education, support, and coordination, as Dr. Fields previously reviewed. For participants who qualify for caregiver respite, we work with our community partners to provide that in-home respite service. So the guide service area you see here is different from some of our other Gilchrist programs and is based on the territory served by our current respite partners. So this is different than, for example, our hospice service area, which now spans from Washington County in Western Maryland to Northern Virginia. Right, next slide, please. So who qualifies for the Gilchrist Guide Program? So individuals who meet the Medicare guide model eligibility criteria that Dr. Fields reviewed and reside within the service area shown in that map are eligible for our Guide program. So Guide services are provided independently of all other Gilchrist programs. So you may notice that's a little bit different than some other programs that operate in the area. So if providers, community partners, patients, or care partners would like more information about our Guide program or to make a referral, they can reach out to our team directly at 888-823-8880 or visit gilchristcares.org. And this QR code will actually take you to our online form to get that process started. And we are currently accepting referrals, though we do have a bit of a waiting list, so it might not be immediate. And with that, I will pass it on to the next Guide participant. Thank you.
Thank you, Amy. And next we have the Guide model from the Hospice of Chesapeake, and I think Elizabeth Hayward is presenting.
Yes, good afternoon, everybody. Thank you for having me today. So much like everybody else, we're providing the same services, the care navigation, the clinical services. Our model at Hospice of the Chesapeake is set up with a community service worker as a care navigator, along with a back end of a nurse, a social worker, and a nurse practitioner. We, much like Amy said, we're covering a little bit different of an area than what Hospice of the Chesapeake historically has covered. We've covered 4 counties in the state of Maryland, all of Anne Arundel, all of Prince George's, all of Charles County, and all of Calvert County. Initially, we were only given zip codes in Anne Arundel and Prince George's County, and that's the entire counties. We cover all patients there. We are looking in the next 6 to 12 months to expand into both Charles and Calvert County, so our footprint is the same for all of our service lines. Pretty much to eliminate confusion for people, because it starts to become a little murky when we can do this here, but we can't do this there. And we might look at expanding it even further, just because of the fact that there's not a lot of boots on the ground Guide participants in the area. So we want to make sure that the people are getting what they really need. Next slide, please. And so our eligibility is going to be the exact same as everybody else's. They need to have they need to meet the criteria that CMS has set forth. Much like Amy, it's taking us a little while to get to people. I mean, there's been a lot more interest in this than I think that anybody really thought that there was going to be. And we have succeeded in crossing the line to successfully be able to provide respite, which has absolutely catapulted that because everybody wants that benefit. And we've found it's been a little bit challenging, but we found ways and means to be able to make sure that people get the respite that they so desperately need. And we're really working hard as an organization to provide care for people in the community and have them age in place more than ever, because we know that there's just going to be so many more dementia diagnoses coming through. And I think that we're trying to position ourselves much like other organizations to make sure that we can provide this, and that this doesn't just become the pilot that it is, but becomes a real CMS benefit. Thank you very much.
Thank you.
And next, I think we have Leanne Eagle from the Living Well Center to present the Guide model that they're working with their partners. Leanne?
Here. Okay. Hi, and welcome everyone. I work with Wendy, and we actually have been very active, and we actually have partnered with the CCS Health to be able to offer Guide where like say on the Eastern Shore and the other areas where that they are not services for Guide. So we partnered with a outside organization to be able to do that. We actually are currently taking, my patients. It's going extremely well. We have the same, the same type of criteria as anybody else. We're really lucky. We were a star state for dementia and so we're very fortunate that we're able to work with CRISP and being able to get those diagnosis codes pulled across for these other community-based organizations. We're working with the Central Maryland AHEC, with the coastal pharmacy. We're working with the Chinese and the Chinese and culture center. All that's going extremely well. We're very excited to partner with Hopkins and to partner with MedStar and all these other locations to help with the numbers when they need support. We're there. We have several different providers of the respite. And that's currently where we are. I'm going to ask Wendy, is there anything else you'd like to add?
I think you covered it. We do have a QR code as well for intake for services or support if you're interested in the program. We are expanding our territory. And again, that is based on respite coverage, like we're all trying to do is secure respite in areas where there is need. So this is our baseline list right now, but we are adding to it other service areas. And with that, one of our partners, we are an umbrella license for the CCS Health Span, which is virtual model, Central Maryland AHEC. Trajan A, I think you're on the call.
Yes, I am here. Good afternoon, everyone. And thank you for having me speak today, Wendy and Leanne. As stated already, we are their partners. Um, Everyone spoke to and attested to what it is that the guide program does, and ours is also similar to that. So I'll just add that we have a large service area covering Hartford, Cecil, Baltimore County and City, Howard, Anne Arundel, Prince George's, Charles County, as well as Carroll and Frederick. So I apologize that that is not there. We work with several different respite agencies to help cover that majority of the area. Next slide, please. And same as eligibility as everyone else, the traditional Medicare, dementia diagnosis, and living in the community, not in a nursing home, and they may enroll with or without their caregivers. And I also just have listed our referral process, of course, the eligibility screening, the assessment, and also our care navigators are all community health workers. Right now, we are working with 3 and training more. So we are continuously growing and we are accepting referrals right now. That's about it for me. Thank you.
Thank you. Thank you so much. Well, it's been an informative session. So I'm going to throw out the first question or make a comment, I guess, is that there are some things that make people not eligible. And I noticed that I think on one of the slides that we hadn't really brought up. They can't be in an assisted living or a nursing home or a PACE program. Is that correct?
That's correct.
Okay. Can they live in a independent, though, senior apartment building? That's more independent. That they're fine for that.
Yes.
Yes.
Okay. Okay. I think we have several other questions. How do we get the Mid-Shore, Eastern Shore population aligned as partners that you would work with?
I would say we're going to move in that direction pretty soon. We were just trying to secure our partners here on the Eastern Shore first, and then we will move up the shore.
Okay. Thank you, Leanne. There's a question about Montgomery County. What do I use as far as outlines for caregivers for dementia clients? I think you're asking, is there a general guide model or is there a program specific that you want to be able to share with them? Who asked that question? Lynn, do you want to clarify? You can unmute yourself.
Hi. So I'm just wondering because I work in Montgomery County as a caregiver slash CNA. I was wondering if any guidelines you guys could provide for me as being, or tips even, anything that could improve? Because I was just chiming into the meeting a little bit late. So you did mention Eastern Shore, everywhere else. Did you mention Montgomery County at all, or you did?
Yeah,
Okay.
I think several of the groups mentioned that they cover Montgomery County. I think,
Oh, okay. That's good.
if
I
I'm not
just probably
mis
didn't hear it then. I came in late. Thank you.
correct me if I'm wrong. I think Hopkins covers Montgomery County.
Yes, yes, yes.
Yes, and Leanne, do you cover Montgomery County?
Our my Chinese culture center is doing Montgomery County as
So
well.
you have the Chinese culture. And then Gilchrist, did you cover Montgomery County?
We do not. We cover parts of Anne Arundel, but not Montgomery.
Parts of Anne Arundel.
And we
Okay.
don't either, Jane. Montgomery's not on the Hopkins list. I was just double checking.
Oh, it is not. Okay. So we are limited in Montgomery. So that's good to know.
Okay, all right. Thank you. Just wondering if
But
there's anything I should know that I don't know as a certified nursing assistant at this time. Anything about Montgomery County, any policy updates, anything like that, or there's nothing?
I would say if you go to the Maryland Living Well Center of Excellence, there is a QR code that you could scan in order to
Okay,
get a services. So you
I
can
see.
scan that QR code. It will send us it will send the Maryland Living Well Center of Excellence a referral, and we will take care of it there. It's a general guidelines. Someone has to have
Yeah,
street
I mean, although I
Medicare and
do,
all of those guidelines, but I believe we've all covered those. If you didn't, we
I
can
see.
get them to you.
I work in my company's based off in Frederick County though, in Frederick, Maryland. So I have clients up to Annapolis and Frederick and Montgomery County, just so you know. That's the range of clients I do in their homes. But
yeah, so some of the programs do mention Anne Arundel County, and I think Leanne's group is looking at expanding to Frederick. But
yeah,
I don't
yeah.
think it's
Coverage
quite
with
full.
Central Maryland
That's
AHAC.
good.
Yes.
Okay. Thank you
Yes.
for expanding to Montgomery, Frederick County. We need more. Thank you.
Okay. And Leanne, I'm going to throw this out to you again, and anyone else about Talbot County. Is that an area that you're working with? Isn't that with one of the groups, your co-partners?
Well, we are looking to expand to the Mid Shore. We have not yet done that. We've just been focused on the Eastern Shore. We just did hire somebody full-time down here. So we're looking to expand into that Mid Shore.
Okay. And Wendy, there's a question about Western Maryland, Washington County. We were just talking about that beforehand.
Yes, Central Maryland AHAC is one of the challenges to this program is securing respite in the zip codes for coverage, and that we're in the process of securing additional respite sites. So I believe we, along with other guide agencies, are all challenged with getting that coverage, but it is happening, and it's a long and lengthy process to get CMS approved in that area. So challenges in
Okay.
the midst.
So Tammy mentions that Dr. Fields mentioned that only individuals that are considered to be moderate to severe stages can receive respite care. Is that only Hopkins qualification, or is it true? I think what you were addressing, Dr. Fields, if I'm not mistaken, was the importance of describing the caregiver stress and burden that they feel in that assessment tool, that's relevant also to respite, if I'm not mistaken.
Yeah, that is relevant. My understanding is that in terms of dementia staging, only moderate and severe people in the moderate and severe stages of dementia qualify for the respite benefit. But any other program, please jump in. I'm not as intimately involved in
That's
that.
correct. You're correct, Dr. Fields. Yep. So fast stage 5 or above, basically. but people
Okay.
can still be in the guide program without qualifying for respite, and we can continue to evaluate every 6 months and submit to CMS again, and they can reconsider and increase the tier that would qualify you for respite. So always still better to get on to get the guide program as soon as possible so we can continue to work with you and support you. And then when the loved one becomes, or the person living with dementia becomes to the point where they are eligible for respite, we'll make sure to get that approved for you as soon as possible.
Oh, thank you. Mark writes, if an individual doesn't have a formal diagnosis, will guide help receive that formal diagnosis?
I'll
Ma-
let anyone else chime in. At least at this point in our program, I have not seen that happen, but it's been a rollout for Hopkins, really starting with our dementia clinics specifically, and kind of expanding. So to the best of my knowledge, we've not been able to do that, but we do try to guide when patients call and talk with our program manager. Penny tries to guide them to where they potentially could get a diagnosis. But I'm interested what other programs their policy and experience are.
We're essentially doing the same thing at Hospice of the Chesapeake. We're giving them referrals out. We're hoping to have a partner that we can work with a little bit more collaboratively to get those diagnoses a little bit quicker, because unfortunately, I'm sure that everybody else is hearing this. Getting into a neurologist in the state is incredibly time consuming and challenging. And I was actually talking with my private primary care provider the last time I met with her, because they're being tasked with doing these diagnoses all the time. And I didn't understand fully the amount of paperwork that goes into being able to establish a full dementia diagnosis with all of the required testing for it. So apparently it's extremely cumbersome for people. So I think finding people to do it is going to be very challenging.
We do have the capability with our CCS Health, Care Coordination Systems Health, and the Health Span Partners Comprehensive Dementia Care, our virtual platform. We do have the ability to assist with that diagnosis. We're very new to this guide work, but yes, we do have the capability to do that.
Thank you, Wendy.
Mhm.
Someone writes in that for counties that are not serviced, should we wait or look for possibility of future service? And I guess that depends on, I'm going to say, how the guide programs can expand. I feel like they're already overwhelmed if I'm hearing everyone correctly. So I'm not sure expansion. I think the virtual platform that Leanne talked about and Wendy is certainly looking at avenues, and I guess being creative. But certainly welcome anyone's insight that's in the field.
Leanne, you're on mute.
I would say the hardest part of this is the getting those on my respite sites on my CMS accredited. It takes, I don't know, Dr. Fields or Liz or anybody's had this experience. It could take, we've had up to 3 months to get these places accredited. So we're at their mercy. So it's not that we don't want to do it, it's just that we have to, like, I'm trying to get like assisted living facilities now accredited, because we have people that want more than just a 4-hour stay or whatever. They want somewhere to take their loved one for 2 or 3 days. So that's where we're putting some effort in now, and we're struggling finding those that are wanting to do that, because and that's basically because the Medicare rate is lower than what they would get paid. And please, somebody correct me, it's like $334, and it's probably not enough. So that's where we're struggling.
I would agree with you on that. We have a small handful of providers that we're using, and we got MOU signed with a lot of people, got a lot of people approved, but they weren't willing to adjust their rates at all. So we have a small handful of people that we have partnered with. You know, really what they're hoping for is that if we get in there with the guide benefit, that the family's actually going to hire them for additional care. I mean, that's, that's the long and short of what it is. I mean, they're a business too, but, I would say I probably submitted between 10 and 15. I think I got 8 approved. It probably took at least 90 days to get them approved. And then out of those, I think I have 3 or 4 that will actually entertain the reimbursement. So
Yeah, I
it's
just
not
wanted to
easy.
share that as one of our struggles.
So it sounds like there's still a lot of startup red tape kind of going through as you get these partners on board with respite care. And the total dollars someone can get if they qualify is it
It just
2,500?
increased from 2,500 to 2,625 as of July 1st.
Okay. But it has
Right,
to
and
be
that
a licensed, designated either facility or agency for in-home care,
That is
correct?
approved by
They all
CMS.
have to have it, whether you're doing it an hourly or you're doing it a couple days at a time, they all have to have that CMS
Approval.
accreditation. And so that is what has to happen. So that's some of the struggles that we're having here. And it sounds like it's just not us. I think it's
It's
probably
nationally.
across the board.
So, yeah.
And Jane, that roughly equates to, at least our quick math, roughly equates to maybe 70 hours of in-home care, depending on, the exact market rate.
Mhm.
We wish it was so much more, but at least this is the first time Medicare is providing respite. So it's pretty exciting. We hope it will be more.
And it will also cover a day program. So we do have a day program here at MAC called Life Bridges. And there's one at Caswick too that I know we have Adams on the phone. So we've been in conversation. So that will pay out to, I think, and Wendy, it just went up. It was 102. I believe it's 104 now. And it has to be at a 4-hour increment.
Okay.
They also too would have to be approved through this whole process, correct?
Yeah, like we didn't have to because the Maryland Living Well Center of Excellence got a credentialed under
Right.
CMS. We're under MAC, so our day program automatically got
Right.
accredited. But yes, if you're not already, it would have to, would have to go through that process.
So there would be the opportunity for other agencies that had day programs or whatever to get accreditation to be able to utilize this service in-house.
But of course, just because we have one here, we have to give we give them all the options. Like, here are your options, right? Like, just because we have the day program doesn't mean that's in the best interest. They may choose to pay still privately for the Life Bridges program and use those respite funds for something else. It is up to the family.
Yep.
Okay.
How does
Well,
a day program,
Oh, I'm
sorry,
sorry.
how does a day program, like who should they go through to try to get this accreditation? Or how do I get them started with that?
It depends where you are and because you have to be aligned with either like someone like we align with the CCS Health. You'd have to align with either with us under CCS Health or Johns Hopkins or Gilchrist, or you'd have to be aligned with one of those major or first, right?
Okay.
In order to be able to do that.
Okay, thank you.
Well, we're coming to an end of our time. Somebody asked about the 90 days someone mentioned. I think what they were talking about is that in order to become a respite part of your program, they have to submit it to CMS for approval, and it takes up to 90 days. So I think that was the 90-day comment.
I just want to say about that, I can't say that they have 90 days. They could have even more than that. That's just what my experience has been. And I think that anybody on this
Absolutely.
call,
Yes.
Doesn't happen.
CMS is going to do what CMS is going to do. And we're
Not
just
happen
we sit pretty
overnight.
and wait.
We're at their
And
mercy.
it could be shorter or longer. We have no control.
Yeah.
Yeah, it doesn't happen overnight. Well, this has been so informative. I thank you guys all for your information. I would tell you to reach out to the programs if you have questions in your area. You know, Ask the Experts series is to really bring information to the front of all of us on the front lines as well as our caregivers. So certainly we hope we're doing that. We look forward to Dr. O's presentation in September. And in October, we're having the PACE programs, another model of care that people tend to forget about. And we have 4 PACE sites in Maryland now, which is new the last couple of years. So come October, and we're building. And if you have ideas for us, please share them with Wendy and I. We'd love to hear them. Thank you all for joining. Have a great summer.
Great.
Thanks, everybody.
Thank you.
Thank you.
Thanks again,
Thank you.
speakers.
Thank you, to Dr. Fields.
Thank you.
Appreciate y'all.